Okay. So I got some case studies for us to go over. We got some derm ones and some pulm ones. We'll go through them together. So the first one's pulmonology. Okay, so 68-year-old male presents to a, yes, you want these?
Can you upload this for us?
You want it right now?
Yeah.
Okay, I can.
Sorry.
Yeah, it's fine. I just go on Canvas and do it. Okay, see if you get them. Okay. Okay, it's uploaded. You guys have it now. Uh-huh. Okay, so you have all the stuff now. Okay, so 68-year-old male. So what age range are we talking about here? Almost elderly. Um, Adult, 65 and up. Complaining of 5 months of mild cough, increasing dyspnea and occasional dyspnea on exertion. Denies chest pain, no fevers, but states his sputum is frothy and sometimes looks pink. Okay? So that's what he's presenting with. So what are you thinking of right now? Okay, so emphysema is one thing. What else could it be? What else? Frothy, sputum, CHF. Does that show up like that? We talked about hydrostatic edema, pulmonary edema. Okay. On PE, lung exam reveals crackles and rhonchi. What does that mean? There's fluid in the lungs. Okay, they have pulmonary edema, crackles and rhonchi. Oh, I know why I can't do this. Well, let me go to the, hang on. All my animations aren't there. Okay. Start. Okay, here we go. Okay, so pulmonary edema, cardiogenic. It's the cardiac cause. Why do we know it's cardiogenic? What was in the history? What did the patient have 2 years ago? An MI. Anytime you see a patient with any type of cardiac history and you don't know what the ejection fraction is, just assume that they have a weak heart. They had a heart attack in the past, so we know they have a weak heart. So this is cardiogenic. And what are the typical causes of this type of edema? What are the diagnoses that would cause you to have a cardiogenic edema? Heart failure, CHF, left ventricular failure, and pulmonary hypertension can also do it as well. And what's the pathophysiology behind the pink frothy sputum? Why is it pink? Blood from what? Capillaries are bursting due to the high pressure. Capillary hemorrhage. Okay, everyone good on that one? Makes sense as you go through it? Why they had CHF? Because they had a history of MI. Now they're coming with shortness of breath and breathing problems because they're fluid overloaded. You got crackles on the physical exam, which confirms that they have pulmonary edema. Given the history of the patient, that way they're presenting, heart failure. Next one, 35-year-old woman comes to the ER with shortness of breath, long-standing history of anxiety. She's taking oral contraceptive pills and smokes a pack a day. Okay, so what are you thinking of right now already? What kind of state is this person putting herself in? Hypercoagulable. Why? Oral contraceptives and cigarette smoking. So we know she's got a high chance of developing a clot. Now on physical exam, heart rate is 120. Is that normal or fast? So she's tachycardic. What about her breathing? So she's tachypnic as well. Tachycardic, tachypnic. She's got a history of taking oral contraceptives and smoking. Start thinking, oh, maybe she's got a clot in her lungs. But you also notice Erythema in the right lower extremity. What is that indicative of? What are you worried about now? DVT causing a clot. So what are the diagnoses? Are there more than one? So it's two, right? You have a DVT and you have a pulmonary embolism. Now, when you record this in your assessment and plan, you're going to say pulmonary embolism secondary to DVT. And you would say then after that, patient is now on heparin, blah, blah, blah. Like every time you write an assessment, write your plan right after. What are you doing for that? They're on hypertension. Okay, their blood pressure controlled, continue their normal blood pressure medicine, or BP's controlled, no changes to meds, whatever. So they have those diagnoses. Why are they tachypnic in the hyperventilation? Why? What are they trying to do? CO2. Very good. And what are the risk factors? Smoking and the oral contraceptives. These are where these risk factors come into play when you start saying, well, okay, they have a clot. Why would this young lady have a clot? Well, she smokes and she's on oral contraceptives. Okay, that makes sense. Let's follow that thread and see where it goes. Okay, next one. 66-year-old male comes to the ER complaining of shortness of breath, cough with sputum, no history of fevers. What does that tell us right there that he has no fevers, but he's got this productive cough? Is it infectious? No. So we know something else is going on. 2-pack per day smoker, BMI is 32, and on exam you notice he has a little bit of a blue tinge around the lips and the face. He's also in mild distress, and 2+ pitting edema in the lower extremities, bilateral. Why is that important that I put bilateral in there? It's not a DVT, this is volume overload. Too much volume in the system. So, but looking at the other issues, what's the diagnosis for this one? Bronchitis. Very good. And why do they get edema? Okay, all this inflammation ruins all the cilia. They can't remove it. Plugs are there, causing decreased ventilation. This whole process for these mucus plugs that form with chronic bronchitis, where they can get the air in, but they can't get it out because the mucus plugs the exit. So you get air trapping, so they start filling up. All this problem causes hypoxia, resulting in pulmonary hypertension, which then translates to the right side of the heart, which then causes right-sided heart failure, which is why they have bilateral lower extremity edema. The right side of the heart is having the problems here due to the cor pulmonale, essentially, the overlying pulmonary issues that can cause right-sided failure. And what are some main pathologic differences between bronchitis and emphysema? Cough. So chronic bronchitis, disease of the airways, mucus production, so it's an airway disease. Emphysema, disease of the parenchyma, alveolar destruction. This is a tissue problem. It's the parenchyma with emphysema. The treatment is the same, but how they got there might be different. In order to, I don't think I have it, no. So in order to make the diagnosis for chronic bronchitis, what has to be the conditions? 3 months, 2 years. So 3 months out of the year, 2 consecutive years, now you can say they have chronic bronchitis. Some people might just get bronchitis in the wintertime, and it lasts for a couple weeks. You take some inhalers and you're okay. That doesn't mean you have chronic bronchitis. You just got an acute bronchitis, upper respiratory infection, and you're okay. But if you have all these symptoms and that bronchitis lasts a lot longer and it comes back every year, then it's chronic bronchitis. Okay, next one, 21-year-old male presents to the ER complaining of shortness of breath, long history of seasonal allergies, and allergic to smoke. So when we mention these history of seasonal allergies, allergic to smoke, start thinking of what type of reactions this person may start having. Keep going. You're right. Type 1 hypersensitivity reaction. So type 1 hypersensitivity, atopy, the allergies, the IgEs that come out. So they have a history of seasonal allergies and allergic to smoke. So already we're telling you that this person is sensitive to pathogens and stuff floating around the air. Notice that his college roommate smokes. He ran out of his albuterol last week. He's hunched over, moderate to stress. Pulmonary exam, physical exam of the lungs reveal inspiratory and expiratory wheezes in all lung fields, and pulse ox is 90% on room air. So if you saw this in a patient when you're walking in, what are you going to assume this patient's having right now? Asthma attack. So acute asthma attack. What's the pathophysiology behind the disease process? Make sure you remember all that smooth muscle hypertrophy, the hypersensitivity reaction, mucus production, increased vascular permeability, airway edema, so just swelling, permeability, so all that fluid gets into the area, causing swelling of the tissue, hypersecretion of mucus, further making that lumen smaller, turbulent flow with this mucus everywhere causes the wheezing to happen. And what were the causes for this patient? Yep, no albuterol and constant, stimuli that can trigger his asthma. Always ask asthmatic patients, did you run out of your medicine? Because half the time they probably did. So ask, do they have a rescue inhaler, which is what albuterol usually is. It's a rescue inhaler. They have it just in case they need it. And obviously this patient ran out of it, so they had problems. And what's the significance of hypercapnia in a patient with acute asthma? Is that a good thing or a bad thing? Bad. Why? Well, they're acidic, but what caused it? Why are they having respiratory acidosis? What's going on? They can't get the carbon dioxide out because their respiratory muscles have fatigued. They've tired out their own body, their muscles are done, so they can't breathe as well anymore. They're not moving air. CO2 starts to build up. So not a good sign when they have hypercapnia with an asthma attack. And what would the VQ ratio be? Would it be higher or lower in a patient with acute asthma? Lower. Why? What number is going down? The V. The ventilation is reduced because they can't breathe as well. The perfusion still stays the same. So it's decreased. So all the COPDs, anything dealing with ventilation issues makes the VQ go down. So COPD, chronic bronchitis, asthma, emphysema, they're going to have low VQ ratios. If they have a perfusion problem, DVT-PE, and they have a PE, the VQ goes up because you're losing the perfusion. Okay, any questions on those poem ones? Very straightforward. You guys getting the hang of how to read these vignettes now? How to look at the information that we give you, how to use it to start thinking about what am I worried about these patients. Okay, we have a couple of derm ones and a Kahoot. A 25-year-old woman presents with a rash, has developed over the last several weeks and seems to be progressing, so it's getting worse. On exam, several plaque-like lesions over the extensor surfaces of both upper and lower extremities. So why is it important that we list what surface? Because some diseases are only on the flexural surfaces, some of them are on everything. So knowing which ones are flexural surfaces and so forth. Plaques are erythematous with a silvery scales, sharply demarcated, so we know they have really good borders. Okay? And so what's the most likely diagnosis? Psoriasis. Is it a skin disease, genetic, environmental, or both? It's both. Okay, strong family history and obviously environmental as well. So yes, this is psoriasis. And this is just a big paragraph, so just read it on your own later. But again, why they have the plaques, why do they get the scales, why are they erythematous? So this kind of describes the process for these skin lesions, why they have these issues. Couple of key things. I don't think I have it on here, but remember the Reet ridges. That's in this one too, I think, with psoriasis, the Reet ridges. Okay. What immunological defects have been implicated in patients with this skin disorder? Yes.
I have a question.
Yeah.
So I'm looking at the derm pathophys right now,
Mhm.
slides, and it says for psoriasis, it said lesions can occur at any site but the scalp.
But the scalp? Okay.
Yeah. So can it be on the scalp?
I will look that up. Email me.
Okay.
I'll verify. I'll make an announcement later. I want to make sure. Um,
I have a question.
yeah.
The nails.
Yes.
Are they always affected?
Not all the time, but they can be as well. The nail beds can be occluded as well. Okay, with these patients with psoriasis, remember it's a CD8 that's the issue. They start infiltrating and causing the issues. Okay, next one. 35-year-old woman recently returned from Africa, presents to the clinic with complaints of a rash to both arms that developed during the trip. Meds, she's on chloroquine for malarial prophylaxis. Past medical history, unremarkable. PE, skin, multiple small violaceous plaques on flexor surfaces of bilateral arms. Lesions are angular with flat tops. So they're like trapezoids? Is that what it's called? Can't remember that. I asked Eli, he knows. Minute white streaks are noted. What is that called? Wickham striae on the surface of several lesions. So what's the most likely diagnosis for this one? This is your lichen planus, and the etiology is due to the chloroquine the patient's taken for the malarial prophylaxis. That does happen when you go to certain countries. There are certain vaccines you have to get if you go to certain places in the world that have high prevalence of these diseases. And obviously prophylaxis for malaria if you're in different parts of the world. Malaria is a bigger problem. Skin lesions are formed. Again, read all this. So T lymphocytes get into the papillary dermis, and that's superficial dermis. We get vacuoles appearing. Colloid bodies with eosinophilics. We know it's an allergy response. And mature lesions have CD8. Those are the killer T cells. The CD4s are the helper ones. And your cytotoxic T cells are in there. Why they get the violaceous papules of the minute striae, dense infiltrative T lymphocytes, and obviously vacuoles. So those are the reasons why they get those certain conditions. Next case, 27-year-old woman comes to the urgent care clinic with a red, itchy rash on her arms and legs that developed suddenly the day before. So we know it's an acute issue. It just started, so it's not a chronic problem. Rash is now spreading to the trunk, and she denies ulcers in her mouth or genital area. So what type of surfaces is this one not affecting? Mucosal membranes. So just we talked about what surfaces this lesion appears on. Also know where. Is it skin or is it mucous membranes? Past medical history, she has positive for genital herpes. Last outbreak was 2 weeks ago. She's on acyclovir for the genital herpes as needed. And she did not take the acyclovir with her last bout as the RX expired. So she had an outbreak of genital herpes and didn't take her acyclovir. Physical exam, multiple erythematous papules to the arms and legs and trunk. Lesions have a central area of duskiness. They appear like bullseyes or target lesions. No mucosal lesions are noticed. We know, again, it's not going into the mucous membranes, just the skin. So what's the most likely diagnosis for this one? Erythema multiforme, the target lesions is the clue, the target type lesions. There's other things in the vignette as well. Why they're formed and in what ways is this similar to lichen planus? Bless you. Inflammatory infiltrate versus dense inflammatory infiltrate, but they both have the T lymphocytes are there. And In erythema multiforme, they have widely distributed vacuoles. In lichen planus, it's vacuoles in just the lower epidermis. Yep, so what factors may have triggered the rash in this patient? HSV-2, genital herpes. Remember, herpes simplex is one of the causes for the erythema multiforme. And what is responsible for the target type lesions? Why do they lose that interior erythema? Necrosis. This tissue dies off, therefore no more red blood cells. They turn dusky compared to the area around it, giving you that target type lesion. And I think this is the last one before the Kahoot. 65-year-old male comes to the derm clinic with blisters developing on the abdomen and extremities over the past week. Initially, lesions appeared as red patches, so that's that erythematous base, followed by the blister formation. So now we have blisters. Because we have blisters, what are we thinking of right off the bat? The bullous pemphigoid, and those things. They're pruritic, but not painful. So what does pruritic mean again? Itchy. So they itch, but they're not painful. No other complaints, and denies mucous membrane involvement. Okay, clinical pictures believed to be most consistent with bullous pemphigoid. So what is the major differential for multiple bullae? So this is your bullous pemphigoid versus bullous pemphigus. Pemphigoid. Better prognosis with the bullous pemphigoid. The bullous pemphigus is the worst prognosis of the two. And in this case, it was pemphigoid, tense bullae with that erythematous inflamed skin. Okay. And what's the mechanism for that blister formation? Layers separate. Okay. Yep. Detachment of the epidermis from the dermis. You have this hole there now that gets filled with fluid to fill it up. Okay, last one. 45-year-old woman presents to the clinic with a rash on her legs for 2 months. So we know this is chronic, it's not acute. Rash became soon after babysitting her niece who had strep throat. She had a sore throat herself, took 2 days of antibiotics and from a prior prescription. Physical exam, skin, anterior legs, scattered, ill-defined. Is that important? Why? These lesions are deep. They're in the subcutaneous fat layer. They're going to be the borders are lost in the layers getting up to light, so you lose it. Tender to palpation. What's the diagnosis? This is your erythema nodosum. Cause strep pharyngitis probably caused it. Never really completed it because you only took 2 days of antibiotics. Another question for your patients when they come in, they're sick and you give them antibiotics and they come back and they're not better. Did they take the full course of antibiotics? Because if they don't, they'll come back. If they did take the full course of antibiotics and they're still sick, what should you do? Change antibiotics, try a different one. See what's going on. So again, persistent erythema nodosum. What are some other causes of erythema nodosum? Sulfa, OCPs, and inflammatory bowel disease, so your Crohn's and ulcerative colitis. And mechanism, remember septal division in the fat component, so it's in the subcutaneous fat layer in the skin. That's where the lesions are. The necrosis occurs in the subcutaneous fat. And histological findings, again, fat necrosis, or that septum between the fat lobules is inflamed and necrosed as well. I did have more. Okay. I thought I almost done. Okay, I think this is the last one. 52-year-old African-American male comes to the clinic with a rash that has been worsening for several months. So again, it's chronic. This is not acute. So always trying to figure out, is this an acute problem or a chronic problem? Because different things will happen different ways. Skin, multiple red-brown dermis-based papules to the trunk, arms, and face. Several are noted under the nares as well. So they have these little nodules everywhere. What's your most likely diagnosis for this one? Sarcoidosis. You get a chest x-ray. What might you see on the chest x-ray? Hilar adenopathy. Gets bigger from swollen glands. And skin biopsy you can do of those lesions as well. What other organ system is at risk for disease involvement? The lungs, right? Because you're breathing in all this stuff, and those nodules can grow in there. And histopathological features, granulomas get deposited in the dermis. They're not necrotic, just collection of macrophages in the area that makes it those nodules form. Yes, we are done. Okay, let me pull up the Kahoot.
Like, you assume that what's going on here is going down there, because the sarcoidosis did
It could, yeah. Remember, we're talking about just heart failure. It could be anything that causes that. The mitral stenosis is one of them. Okay, what are Langerhans cells? So where are they, first of all? The lungs or the derm? Okay, bone marrow derived. So there are, it's the, remember, there's two types of protection we have for cells, melanocytes and Langerhans cells. Okay, how would you describe a 5 millimeter non-palpable area of decreased pigmentation? Does it matter? You got to know both. 5 millimeters is half a centimeter. Okay, this is a macule. Patch is bigger than a centimeter. Okay, 45-year-old female with rough, thickened skin resembling tree bark. Work backwards on these questions. Figure out, okay, fine. Erythema nodosum, that doesn't have any tree bark. What does erythema nodosum look like? Bruises, that deep thing, deep red. Chronic eczema is tree bark. What's the major difference between a vesicle and a pustule? Does location matter for these two? Demarcation? It's contents, what's inside. Pustule obviously has pus, red, white blood cells, all that stuff. Vesicle can just be like liquid, water, serum. 64-year-old male, chronic alcoholic. You notice spider-like blood vessels on the nose. What's that called? Telangiectasia is very good. Okay, 23-year-old female, petechial rash on the face, drunk at UF game. But they wouldn't have petechial. Why would you get, what is petechia? Blood bursting. No, you have a different reaction. It wouldn't be petechia. Okay, which one is a spongiotic dermatitis? So it's spongy, so it's got a lot of water in the area, so a lot of leaky. So on the derm stuff, make sure you know the diseases we talked about, the type of inflammatory they are. This is your reaction. What kind of hypersensitivity is this? 4. Type 4, delayed. Which of the following is also seen in sarcoid? Very good, very good. Okay, 64-year-old African-American male, bilateral hilar lymphadenopathy. On x-ray, also has fever, arthralgias, and uveitis. What's the diagnosis? Okay, now, lupus pernio. What actually is lupus pernio? It's the nodules under the nose and the nares. That is lupus pernio. Lofgren syndrome is, yes, they both have sarcoid, right? But the underlying thing that goes along with it, Lofgren's has fever, arthralgias, and uveitis along with it. There's a slide that describes both of them together on the same slide. Okay, 15-year-old with acne vulgaris, told not to pop his pimples because it can cause what reaction? Very good. You pop the follicle, so all those products of inflammation that were trapped in that follicle now spread to the surrounding tissue and can cause more issues in the next follicles nearby. So you don't do that. Accumulation of keratin and accumulation of the shed keratin sebum, that's actually what causes the blockage in the first place. The popping is not going to cause more accumulation inside the pore. And rupture of lobular flat, nothing to do with that. Okay. What antibodies are produced in response to an allergen in atopy? Someone's IgE is floating around or sneezing. Okay. She's the only one, huh? Okay. Okay, during an asthma attack, what would a lung perfusion, a VQ scan show? High, low, or no change? This is asthma. Very good, it's low. Now, I want to explain something. So, normally, if someone comes in and you suspect that they have a pulmonary embolism, the normal test that we would normally do is a chest angiography with contrast. So we inject contrast and we see in the lungs where the blood stops perfusing because there's no contrast there and it can't get there. So you'll see parts of the lungs that don't show. The problem with that is you have to give a patient dye, contrast dye. Who should not get contrast dye? Kidney patients. Don't give it to them. It does what's called a contrast-induced nephropathy. The kidneys can't get rid of the contrast dye and it builds up and causes issues with the kidneys. So you can't give them a CTA, CT angiography with contrast because they can't get it. So another test you can do is called a VQ scan or a lung perfusion scan. Basically, it's a nuclear type of test. We take out a little bit of your blood, we tag your red blood cells with nuclear isotopes, we put it back into your bloodstream, and obviously we see where everything glows. So we put you under a nuclear scan, doesn't require any contrast, so the kidneys are okay. That's what a lung perfusion is. It's not used very often, but in patients who have an allergy to contrast dye or they already have struggling weak kidneys, you can't give them the dye. So if you want to rule out a PE, you order a VQ scan. And basically, it's a nuclear type of test. Safe way of figuring out are there any perfusion deficits going on with the lungs. Ventilation, you can just measure by monitoring their spirometry. But the perfusion, we can figure out that way. So that's what a VQ scan is. Okay. Okay, major difference between chronic bronchitis and emphysema. Is the VQ ratio going to be the same? Yes. These are both airway problems. They're not perfusion problems. They're ventilation. O2 sat is going to be normal. Not normal. They're going to be the same for both of them. They're both going to be hypoxic. Respiration rate. They're both going to be elevated. They're both going to be tachypnic, trying to blow off CO2 or get more oxygen. So it's the cough. Which one has the cough? Bronchitis does. Very good. Okay. What's the driving force for polycythemia in a patient with chronic bronchitis? So what's the stimulus to make them generate more red blood cells? So you have to know what polycythemia is to answer this question right, or you will never get it right, or you just guess. So make sure you know what that is. Okay. low arterial oxygen. Remember, let's go back to the kidneys. The kidneys sense the O2 tension, right? And if they see it's low, what do the kidneys produce? Erythropoietin to make more and more red blood cells. So it's a hypoxic, low arterial O2 is what causes more red blood cells to be made. CO2 has nothing to do with red blood cells. All that's going to make us do is breathe more. So you see how this question is, like, are they going to have elevated arterial CO2 in bronchitis and emphysema? Yes, they are. Tachycardic, yes, they are, but the question is asking about the polycythemia. So the answer has to be due to why do they have that. You will have multiple correct answers, but the question, read the question, what are we looking at? What are we looking for? Okay. 65-year-old male, 20-pack year history, O2 sat 86%. Chest x-ray shows hyperinflation with a flat diaphragm. So which lung disease do we learn about that has hyperinflation with a flat diaphragm? So we have a lot of air trapping. Do we mention anything about fluid on this x-ray? Nope. So we can get rid of acute CHF exacerbation because there's no fluid in the lungs, which you would normally see. If it was chronic bronchitis, what would I have to mention about the x-ray? The tram track lines or train tracks, whatever, from pulmonary vascular congestion. You would have that there as well. But this is hyperinflation, a flat diaphragm, emphysema. Okay, which of the following will you see with pulmonary hypertension? Now, I told you the buzzword for this one, so that should clue you in the answer right away. But look at the other answers and find out why they're wrong. Do pulmonary hypertension. Okay. Pulmonary hypertension. Do those patients get left-sided heart failure? What do they get? Right-sided heart failure because you increase the afterload on the right. Right ventricle doesn't like it. It starts to fail. Displacement of the PMI laterally. If you displace the PMI laterally, what is that? What chamber got big? Left side. If the right side gets bigger, I would have to mention what? What would I have to mention if I said the right side got bigger? I would have to give an x-ray. Cardiac silhouette is enlarged. You lose your sternal border because the cardiac sides got bigger. I would have to mention something like that, showing that the right side got bigger. Decreased right heart pressures. Are they decreased or are they increased? They're increased. So plexiform lesions on chest x-ray, yes, I mentioned plexiform lesions is pathognomonic for pulmonary hypertension. Once they get plexiform lesions, the pulmonary hypertension is really not reversible anymore. You can kind of treat some of the symptoms, but at that point, you're not reversing it. Okay, a couple more. Which of the following is an acute cause of cor pulmonale? So make sure you understand now, acute versus chronic. When do they present? How do they present? So cor pulmonale. Which one of those answers would be acute? Even if you didn't know the answer, look at the answers. Which one is the only one that's going to be acute scenario? Pulmonary hypertension, is that acute? Takes a long time to develop pulmonary hypertension. Pulmonary interstitial fibrosis, long time to develop. Chronic pulmonary emboli, obviously it's chronic, it's always there. So, okay. Someone inhaled irritant gases and now has pulmonary edema. What's the pathophys behind this one? So there was a slide that had 4 vessels. First one was the normal one. The second one showed remember the cardiogenic or hydrostatic edema, the different causes. One of them was endothelial damage, one was epithelial damage. Make sure you know examples of each one. So this is in irritant gases. Okay. This is one, again, if you didn't study, you won't know this one. So you can't really think your way through this one. Obviously, the 2 common answers are the one either epithelial or endothelial damage. So in this case, it was irritant gases, so it's epithelial damage. Okay, you perform a thoracentesis and note increased protein on analysis. What are you worried about? So increased protein, is this a transudate or an exudate? Exudate. And I said you're doing a thoracentesis, so where is this fluid coming from? The lungs. What specifically? The pleural space. Now, let's look at the 3 wrong answers. What do they all have in common? Issues with what? What is in common with all 3 of those things? Albumin, right? Protein. And if you have low protein, what happens to your oncotic pressure? Drops. So the suck goes away. So you become more swollen. In this case, the more swelling that you have, but they have cirrhosis, low protein output, nephrotic syndrome, they're spilling proteins into the urine like crazy, or hypoalbuminemia, same thing, low protein in the blood. They're going to be swollen and have swelling. But in these cases, those 3 type of conditions, what type of what type of fluid is it going to be? Transudate. So it's more fluid, more serum, more watery type of stuff, mainly due to high hydrostatic pressure or low oncotic pressure in these cases. Malignancies, cancer will cause an exudative, high protein exudative fluid in the pleural space. Okay, last question. Extended bed rest, cigarette smoking, and recent surgery. Read it right, though. One of you will pick the wrong one, I know it. Who picked the wrong one? Who read it too fast? Yeah. Blue one is not right, guys. It's what caused it. So DVT caused the PE. Okay, guys. Good luck studying. See you all Friday.